Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good afternoon, everybody. I'm Dr. Stephen Dean. I'm a clinical professor of medicine at The Ohio State University, and was asked to give a talk today on something of interest, and I like to give it on the pathomechanisms of lipo-lymphedema. I find this to be a very interesting and now somewhat of a controversial topic. So let's get started. We got a few introductory slides here. You can see here this symposium series has been made possible by the generous support of these organizations. And here's a disclaimer. This is provided for use for you in consultation with your healthcare professional. It is not meant to take place of healthcare services you may need. And please see your primary healthcare provider about any personal health concerns. Critically important slide here to start with. All right, here's my minimally relevant disclosure. We're not talking about therapy, so I don't really think it's that relevant actually, but nonetheless, let's get started. So now before we jump in and talk about the pathomechanisms of lipo-lymphedema, I think it's important that we briefly review a critically important concept from the recently published standard of care for lipedema in the United States. The guidelines, if you will. This came out a couple of months ago. It's actually the #1 downloaded article from Phlebology right now. And look at consensus statement 1.1. Lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes. Again, lipedema, it's a loose connective tissue disease. Keep in mind that fat is a loose connective tissue. In addition to adipocytes, immune cells, and fibroblasts, loose connective tissue has an extracellular matrix composed of collagen and elastin, which supports, protects, and connects tissues. So when you have a subset of patients like the lipedema patient that has dysfunctional collagen, especially elastin, that explains their associated joint hypermobility, which allows these patients to place their limbs in these type of contorted positions. But not only is these dysfunctional elastic fibers associated with joint hypermobility, it also underlies, I think, a lot of the pathophysiology of lipo-lymphedema. All right, so I wanted just a brief review here of lipedema. This is a critically important article that was published by Dr. Wold and Associates at the Mayo Clinic back in 1951, entitled Lipedema of the Legs, a syndrome characterized by fat legs and edema. And they recognize 6 cardinal clinical features of lipedema, which is amazing. It clearly stood the test of time. #1, almost exclusively female. #2, it's bilateral and symmetrical with sparing of the feet, at least initially. Now, not when we're talking about our lipo-lymphedema patient. #3, a component of minimal pitting orthostatic edema, which affects the distal calves, the ankles, the feet, hence this original term, lipedema. 90% of these patients have pain or tenderness on pressure. 75% has a susceptibility to easy bruising. And unique to the lipedema patient is this persistent enlargement of the extremities even after weight loss. But again, I just want to draw your attention to #3. We're going to concentrate on not only the minimal pitting edema, but fixed lipo-lymphedema, the pathomechanisms. All right, and before we go too much further, I think it's a relatively new concept that you started to see it appear, here's 2013 in the International Union of Phlebology consensus document, where they stated the following: that lymphatic failure is responsible for all forms of peripheral edema. And then these sentiments were echoed by Drs. Mortimer and Roxon in this follow-up study in 2014, New Developments in Clinical Aspects of Lymphatic Disease, where they also stated that all chronic edema indicates an inadequacy or failure of lymph drainage. So does this mean that all edema represents lymphedema? I don't think that's necessarily correct. So all edema doesn't necessarily have associated inflammation, fibrosis, fibrofatty deposition, but I think it's fair to say that any type of edema does at least represent lymphatic failure. So this is a very helpful introductory table on the 3 causes of edema in your lipedema patient. This was from the 2018 Spanish lipedema guidelines, Documento de Consenso. And let's go through these 3 causes. Number 1, orthostatic edema, which they state is the most common type of edema that plagues the lipedema patient. And this is edema that worsens through the day and improves with decubitus or elevation. So again, now we have this controversy that begets the question, would you consider orthostatic edema to be lymphedema? Or is it just lymphatic failure? I think there's probably a gray zone there, but something to think about. Then, of course, number 2 would be the edema that's associated with venous insufficiency that involves many of these lipedema patients. And as you know, venous insufficiency is actually secondary lymphatic insufficiency or phlebolymphedema. And I think it's worthwhile reviewing some comments that they made here in this last paragraph on edema due to lymphatic insufficiency. You can see here they state that there is controversy about this edema, whether it's lymphedema associated with lipedema constituting the so-called lipo-lymphedema, or if it's a secondary lymphedema simply due to obesity. And I agree with the authors that I think both of these are probably factors, or they are factors in the setting of lipedema. And again, we're going to discuss these pathomechanisms. And let's start by orthostatic edema and look at the pathophysiology behind why orthostatic edema complicates the patient with lipedema. Now, if you have a dysfunctional veno-arterial reflex, also known as the postural vasoconstriction reflex, you're going to be predisposed to dependent lymphedema or lymphatic failure, excuse me. But let's say it's functional. How does a functional veno-arterial reflex work? Well, first of all, when your limb is placed in a dependent position, the blood flow should decrease. And that's due to an increase in the precapillary resistance. And this precapillary resistance prevents a loss of fluid into the extracellular space or the interstitium, again, when the limb is dependent. And mechanistically, this is driven by neurogenic, especially sympathetic impulses, and then secondary myogenic mediated vasoconstriction as well. So with that thought in mind, this is a really thought-provoking article by Zell and Associates. It was published back in 2014 entitled The Pathophysiologic Dilemmas of Lipedema. And herein the authors posited that the patient with lipedema actually has inflammation of their sympathetic sensory nerves and as well as a peripheral neuropathy. So collectively, this peripheral neuropathy, which by the way is probably a small fiber neuropathy, they refer to as a lipidematous neuropathy, a lipidematous small fiber neuropathy. And when this exists, what happens? Well, when that limb is in a dependent position, that precapillary sphincter does not contract. That allows excess interstitial fluid into the extracellular matrix, et cetera, leading to the characteristic orthostatic edema. So that's how it happens. Now, let's just briefly go through this interesting digression here, if you will, on the stages of lymphedema. And I'm sure most of you have seen these before, and I want to just hone in on stage 1 lymphedema. What is stage 1 lymphedema? Well, this is lymphedema that's completely relieved overnight with limb elevation. What other type of edema is completely relieved overnight with elevation? Orthostatic edema. So I don't think it's unreasonable to assert on some level that orthostatic edema is actually a de facto stage 1 lymphedema. Something to keep in mind when you use that term lipo-lymphedema. Now, we've alluded to this in the first slide that lipedema has been linked to joint hypermobility. In fact, in Dr. Karen Herbst's landmark article she published back in 2015, she identified that half of her patients had a Baton score. That's a pathologic hypermobility score of 5 or greater. Now, why are we talking about this in the setting of orthostatic edema? Well, as I also referred to in that first consensus statement, 1.1, lipedema is a connective tissue disease. What other connective tissue disease is out there that's associated with joint hypermobility? Well, the hypermobility spectrum disorders. This disease exists on a continuum. You can have asymptomatic joint hypermobility. You can have symptomatic joint hypermobility, or even hypermobile Ehlers-Danlos syndrome. And a good portion of these patients, lipedema patients, exist on this hypermobility spectrum. At least half of them, if you go by Dr. Herbst's article. And I heard Dr. Herbst at the AVLS a couple of months ago mention that she'd been in contact with a physician in South America, I believe it was Portugal, where he informed her that in their lipedema series, 80% of their lipedema patients have hypermobility. And that's typically what I see in my practice. I'm going to say it's about 3 out of 4 are hypermobile. So again, back to that original question, what does this have to do with orthostatic edema? Well, here is the potential link. Here's an article that was published in 2017 looking at the cardiovascular autonomic dysfunction that complicates the hypermobile Ehlers-Danlos syndrome patient. And by the way, this is also applicable for any hypermobility spectrum disorder. What are the manifestations? Leg swelling and or discoloration, a dusky purple-red discoloration in the legs after standing for only relatively short periods of time, as seen in orthostatic intolerance, as seen in orthostatic edema. So, gosh, what other disorder is associated with leg swelling and discoloration? Why, the lipedema patient. And again, this is a great example of this overlap that exists between the hypermobility spectrum disorders and lipedema. What a great example of a patient with type 2 stage 3 lipedema that is complicated by orthostatic edema. Now, what I'm pointing out here is, you note that that discoloration that you see there throughout the entire calf and even going up into the lobes of the distal thighs. That's that characteristic erythrocyanotic discoloration that you see in the setting of a dysfunctional veno-arterial reflux. Very, very characteristic, and often overlooked when you're seeing these lipedema patients because you tend to hone in on their swollen legs and pay less attention to skin findings. A lot of times this is misdiagnosed as stasis. That's not stasis, and it's reversible when the limb is recumbent. Now, we've talked about orthostatic edema. Let's move on and talk about lymphedema or lipo-lymphedema, as seen here. I just want to point out here that when you see fixed lymphedema, fixed foot swelling in the setting of lipedema, it's usually associated with a relatively modest amount of foot swelling, as you see in these two examples. You don't typically see the big dorsal hump that you would see in the setting of primary lymphedema or very, very severe secondary lymphedema. It's usually relatively modest. Now, here are the stages of lipedema, and let's go through these. Stage 1, this is the smooth stage where the skin is smooth. Stage 2 is the nodular stage where you can start to palpate subcutaneous nodules. The skin has a cellulitic or a cellulite appearance, it looks like a mattress pad. And then finally, stage 3, which is the lobular stage, and I think that morphology is self-explanatory. Now, you will read or see in some lipedema articles that they talk about a stage 4 lipedema, which is actually, as seen here, lipedema with lymphedema, also known as lipo-lymphedema. I'm not a big fan of the stage 4. I still like to just stage 1, 2, and 3. And the reason why is as follows. Lymphedema can complicate stage 3 lipedema. Lymphedema can complicate stage 2 lymphedema, and it can even rarely complicate stage 1 as well. So that's why I'm not a big fan of that stage 4 categorization of lipedema. So back to our standard of care for lipedema in the US. Let's go to consensus statement 1.12. Women with lipedema who develop lymphedema have, by definition, lipo-lymphedema. Lipo-lymphedema is lipedema that has progressed to clinically identifiable lymphedema. So they have some cutaneous fibrosis, they have some fixed swelling, again, fixed dorsal foot swelling, as you can see in both these examples, relatively modest swelling. And it's a risk that increases concomitant with stage. And here's just examples, and I think that's intuitive that you're more likely to develop secondary lymphedema as one moves through the subsequent stages of severity. Stage 1, less likely. Stage 2, a little bit more likely. Stage 3, more likely to have fixed lipo-lymphedema. Again, self-explanatory. Now, how many of you have read the international consensus document on lipedema? This came out last year. It was an extensive article. I thought it was well written, but I think there were some points that they made in here that I think are definitely contentious. Remember, I referenced earlier, there's some controversy, and this is a perfect example, because what did they say in here about lipolymphedema? Well, here we go. Lipolymphedema suggests progressive lipedema leading to lymphedema. It suggests that lipedema causes the lymphedema. Well, that's true. However, there is no scientific evidence for this viewpoint. I would say au contraire, and I have some scientific evidence I'll show you. And then finally, they terminate with this statement. This lymphedema is then not lipedema-induced lymphedema, but rather obesity-associated lymphedema. And finally, they assert that the term lipolymphedema should therefore be eliminated from lymphology. We'd have to eliminate my whole talk today if that were the case. So, because they say there's no scientific evidence, I think it's worthwhile looking at what evidence is out there that supports the concept in the existence of lipolymphedema. It's not just obesity mediated. Now, here are two relatively contemporary studies. We've got a 2019 and a 2020 reference utilizing functional studies to look for increased fluid volume. Both of these articles came from Dr. Rachel Krasinski's work out of Nashville. Very, very good articles. And look at the first one where she utilized bioimpedance and documented higher extracellular water in the legs of patients. It was higher compared with lower stages of lipedema. That's statistically significant. So that makes sense, right? It's more likely to have more volume in a limb of a patient that has advanced or a stage 3 lipedema versus stage 1. But also, she noted that even in patients with stage 1 lipedema, they had increased extracellular water when compared to an age and weight matched control. So stage 1, why is that significant? Well, stage 1 lipedema patients are typically not your morbidly or grossly obese patients. A lot of these are relatively normal body weight, yet they still have higher extracellular fluid volume. And then here was a follow-up 2020 study utilizing spirometry, which also revealed significantly greater lower extremity volume in patients with lipedema when compared to weight-matched controls. So here we have functional evidence that patients with lipedema do indeed retain extra fluid. Now, let's, sorry about that, I don't know what's going on here. Okay, sorry. Let's look at the lymphoscintigraphic evidence out there to support the existence of lipolymphedema that's not just related to obesity. Here was a 1995 study, old study, looking at 12 patients that had lipedema. All of these patients displayed a marked slowness of the lymphatic system. Now, unfortunately, we don't know the weights of the patients in this article, so we can't really address whether or not there was obesity made or not. But here's where things get interesting. Here's a 2018 reference, Forner-Cordero, 83 patients with lipedema. Half of these displayed abnormal lymphoscintigraphic imaging. And abnormalities in lymphoscintigraphy were detected in all clinical stages of lipedema, even your stage 1. And again, why is that significant? Because your stage 1 lipedema patient is less likely to be obese. And then finally, note that the degree of lymphoscintigraphic involvement bore no relation to the BMI. Here's a 2020 reference. 19 patients with lipedema, 62% had abnormal lymphoscintigraphic findings. It existed in all stages of lymphedema, including about a third of the patients that had stage 1 disease, less likely to be obese. Now, this is a wonderful article. This is the most comprehensive article I've ever seen on lipedema that Dr. Herbst published in 2019. And she came up with a couple of theories about what underlies the pathomechanisms of why does lipedema develop. And the first one, theory number 1, she refers to as the abnormal blood vascular theory. And again, this is all based on the fact that lipedema now is classified as connective tissue disease with inherent loss of elasticity and increased compliance, which may lead to, number 1, dysfunctional elastic fibers that support the lymphatic vessels. Number 2, capillary distortion or dilatation results in abnormal leakage of interstitial fluid that overwhelms the, at least initially, functioning lymphatics. If you assume they are at least initially normal, that may not be the case, but regardless, results in a dynamic lymphatic insufficiency. And finally, these dysfunctional elastic fibers lead to increased compliance of your connective tissues that facilitates their ability to hold on to fluids, proteins, and macromolecules. So you're probably saying, okay, well, that's great. Well, show me some scientific evidence to support that theory. Okay, Dr. Herbst, here you go. So here's another contemporary reference, 2020, Tartaglione, 54 patients, predominantly pure lipedema. So these weren't your grossly morbidly obese patients. And their mean BMI was only 32. So just barely, that's the mean. 75% of these displayed abnormal imaging with this unusual characteristic tortuous lymphatics as seen here. So, gosh, why would a patient with lipedema have a very tortuous lymphatic? Because they have dysfunctional elastic fibers that are supporting these lymphatic vessels, which leads to tortuosity. That same kind of concept happens in the arteries, for instance, of patients that have connective tissue disease. Same concept. And I would say, show me an article out there of a patient population with a BMI of only 32, where 75% of them had abnormal tortuous lymphatics. I don't think you're going to be able to find. Again, there's something unique to the lipedema patient. There is something intrinsically unique to their lymphatics at a large vessel level. And then in this same article, theory number 2 is an abnormal lymphatic vasculature, where she states this fluid accumulation in the extracellular matrix or the interstitium results from a primary defect in the lymphatic vessels. It could be micro, could be macro. So again, you're probably saying, well, show me the evidence. Okay. And before I get there and show you the evidence, here was another, I thought, very thought-provoking comment by Dr. Busso and associates in this 2020 reference, Lipedema, a call to action. And they stated the following: adipose tissue enlargement might not be the initial step in affected lipedema patients, but rather the consequence of a lymphangiopathy and/or microvascular dysfunction. I mean, that is really food. Let me go back here. That is really food for thought. And to me, that makes a lot of sense. Because what do we know about when you have lymphangiopathy and lymphatic dysfunction and you have pooling of lymphatic fluid? It's highly adipogenic. It stimulates fat deposition. Maybe it all starts here at this microvascular level. I think that makes a lot of sense. So back to, will show me the evidence. Okay. We're going to reference again the standard of care lipedema guidelines 1.8 consensus statement, and that is a microangiopathy of blood and lymphatic vessels underlies lipedema pathology. And here is a corroborative 2019 article published in Journal of Obesity entitled Dilated Blood and Lymphatic Microvessels, Angiogenesis, Increased Macrophages, and Adipocyte Hypertrophy. What they did in this study is they actually had the histology specimens that were obtained from lipidematous thigh tissue, and they were compared with age and weight matched controls. And what they found in lipedema patients, age and weight matched controls, even some that were obese, that you only had the dilated lymphatic microvessels in the lipedema population. So there's some scientific evidence. And then here's a 2020 reference entitled Adipose Tissue Hypertrophy. This was a lipedema cohort, obviously. An aberrant biochemical and distinct gene expression in lipedema. Well, what was that distinct gene expression? Well, here's the distinct gene expression. They looked at, here we have 1, 2, 3, 4, 5 genes encoding for proteins. And the one that was statistically lower, so again, they had a cohort that was age and weight matched. And what they found here in the lipedema cohort, they had statistically lower genetic expression of CEBD. And of course, I've never heard of CEBD. What is CEBD? It's actually CCAAT enhancer binding protein delta. And it was significantly lower. They didn't really talk about in the article, well, what's the significance of that? So I went and found the original reference. It was in this journal reference here, Oncogene from 2011. That's not a journal I typically read, but it was very interesting that I found in this article that a genetic deletion of C enhancer binding protein delta in mice resulted in a significant reduction of lymphangiogenesis. So impaired lymphangiogenesis increasing your susceptibility to developing lymphedema. Statistically, so there's a distinct gene expression unique to the lipedema population that did not exist in weight match controls. There's something else going on here at a small vessel and even a genetic level. And then finally, let's talk about chronic venous insufficiency and how it affects the patient with lipedema. Here's two great examples of lipedema patients that you can see their mid and distal calves have been complicated by the little bit of sclerotic tapering consistent with lipodermatosclerosis. So what does the standard of care for lipedema state about chronic venous insufficiency or chronic venous disease in the setting of lipedema? This off the top here, consensus statement 5.4, common venous conditions seen in people with lipedema include increased risk for venous thromboembolism and conditions associated with chronic venous disease, varicose veins, spider veins, chronic venous insufficiency. And that one article I referenced from Dr. Herbst, 100% of the lipedema patients in stage 1 had associated spider and varicose veins. I mean, there's obviously a predisposition that goes beyond just the female gender or even being obese. Now, it's interesting if you look in the literature and try to find information on this association of chronic venous insufficiency of lipedema, there's practically nothing out there. It's just I can think of 3 articles that have referenced it. And one of the articles was actually data from my institution. We looked at 440 patients that presented for complex decongestive physiotherapy with lymphedema. 12% of these had lipedema. And of interest, of this 12% of the lipedema patients in our cohort, half of these patients had evidence of chronic venous insufficiency. This was not just spider or varicose veins. They had evidence of chronic venous insufficiency. And we noted here that although grossly underreported in the medical literature, we identified this hybrid of lipedema, lymphedema, and chronic venous insufficiency in half of our patients. That's the first time it's ever been shown. So lipedema with CVI and secondary lymphedema, if you want to use the term lipo-lymphedema. That's a possibility. So here's, 3 great examples of this triad of lipedema, chronic venous insufficiency, and lymphedema. And that you have to answer or ask the question, well, why are these patients with lipedema predisposed to chronic venous insufficiency? Now, here is pathophysiology of, or potential pathophysiology of why this link occurs. First of all, lipedema, as we've already referenced, is a connective tissue disease. We know that varicose veins reflect abnormal distensibility and structural changes of the connective tissue disease within the vein wall. And finally, we know that lipedema patients are predisposed to varicose and incompetent superficial and deep veins because of the associated defect in the connective tissues of the vein wall. Here is an interesting article on the back. You just can't escape this hypermobile Ehlers-Danlos or the hypermobility spectrum disorders. And right from the National Organization of Rare Disorders, when you look up Ehlers-Danlos syndrome, here's what they state: varicose veins developing at a younger age than usual, unusually widened, twisted veins. Then also they have a list of manifestations that complicate the hypermobile Ehlers-Danlos syndrome patient, including venous insufficiency. And also note here, orthostatic intolerance. Patients with orthostatic intolerance also have orthostatic edema. So again, there's that link, that overlap between the hypermobility spectrum disorders and lipedema, because they're both connective tissue disease. So, and just to wrap things up on the pathophysiology of lipedema with chronic venous insufficiency, I think really what we're witnessing here is a potentially, well, not potentially, it is a virulent combination of this intrinsic or congenital connective tissue disease with a vein wall defect in the setting of obesity. I mean, 90% of your lipedema patients are obese, and so you have to account for the obesity-mediated pathomechanisms as well. So it's both of these things. So let's wrap things up here right on time, 30 minutes. We'll have about 15 minutes for questions if we have enough interest. And again, conclusion, we'll go back to consensus statement 1.12, women with lipedema who develop lymphedema, I will continue to state, have lipolymphedema and have limbs that look like this. And let's go through the potential mechanisms. As we've seen, it's a potential microangiopathy mediated lymphedema. That's been proven by histology studies when compared to age and weight match controls. And then we also have the genetic articles that I gave you as well. And keep in mind, this is occurring in the setting of this ongoing orthostatic edema due to a dysfunctional veno-arterial reflux because of the associated lipodematous small fiber neuropathy, where you don't contract that precapillary sphincter. And then this is also occurring in the setting of a macroangiopathy mediated lymphedema. And there is no doubt obesity is clearly playing a role in their microangiopathic lymphedema. I don't discount that, but I think you have to count for these patients also have this associated connective tissue disease, which leads to dysfunctional elastic fibers that are supporting the structure of the lymphatic wall. So I think it's both. And then of course, this is occurring in the setting of chronic venous insufficiency as well. And chronic venous insufficiency, as we know, really is leading to secondary lymphedema or phlebolymphedema. So those are all the, I mean, just think of all these pathomechanisms that are interacting in the lipedema patient it's not surprising that so many of these patients end up with lipolymphedema or fixed swelling and cutaneous changes. So I will stop there, and looks like we have 3 questions in our chat. All right, let's see. Here's question number 1. How does treatment differ if you have lymphedema or lipolymphedema? I don't think there should be any treatment difference between the two. I mean, they both cohorts have lymphedema, so I would use the same type of compression in both. I think when you are talking about lipo, well, see, I was going to digress here and say that liposuction would be something to consider if you just had a lipolymphedema patient. And again, you'd want to get the body weight down before you consider that. But even liposuction, as you may know, is now used for lymphedema as well. So I don't think the treatment really differs a whole lot between the two. Here's question number 2. My doctor mentioned pelvic congestion. What workup should the doctor do? And thank you, by the way, for the compliment. Well, I would send him to a radiologist that has expertise in pelvic congestion or pelvic venous disease, as we like to call it now, and they could perform appropriate imaging. Just from a pelvic standpoint, I'm going to digress a little bit here and just mention that because lipedema is this connective tissue disease, it's not uncommon these people or patients have pelvic or uterine prolapse. They have a lot of pelvic problems, uterine problems, urinary problems, all related to the laxity in the pelvic floor. So that's something to keep in mind as well. Our next question is there a diagnostic test available for lipedema? And there really is no it's a clinical diagnosis as a whole. And they ask a good question: could a pathologist diagnose lipedema with a biopsy sample? It's possible, but keep in mind those histology studies are all done in a controlled scientific investigational setting, and it's not widely available. I think you'd be hard pressed to find a pathologist that would be familiar with looking at dilated leaky microvessels. So it's not, maybe in the future, but for right now, it's not realistic, unfortunately. And again, there's no definitive blood test, for instance, if you will. I mean, you can find that patients with lipedema, for instance, have elevated platelet factor 4. Elevated platelet factor 4 has been found in lymphedema patients, but no diagnostic test. Clinical diagnosis, which is where I like seeing these patients, very, very unique clinical findings. Here's somebody asking, how can one confirm that they have venous insufficiency? I have pooling of blood on my feet when I have them down, but I did a Doppler ultrasound and was told I don't have it. Thanks. Aha, what a great question. Outstanding question. And this all revolves around the veno-arterial reflux. So the first thing would be you'd have to hope that the person that did the venous insufficiency study was competent, because I don't mean that to be pejorative or anything, but you have to know how to do a correct venous insufficiency study. It's not a simple study, at least for your beginner. So that's number 1. Assume that you have to find out, was the examiner competent? Now, number 2, assuming they're competent and you had no reflux, there's a couple of things that could be going on here. Number 1, it could be weight related. For instance, you can have completely normal superficial or deep venous function in the setting of a reflux study, but yet have pelvic obstruction. I mean, there are studies out there showing that patients that are obese have chronic iliocaval obstruction, and that could explain why you have venous insufficiency in the setting of a negative study for incompetency or reflux. There's a concept of a venous microangiopathy, which leads to all the characteristic clinical features of lymphedema or phlebolymphedema, CVI, and yet you don't document significant reflux. That typically is, again, seen in the obese setting, the morbidly obese setting. And then finally, the pooling that you reference, you're not going to find pooling on an incompetent study. The only way you're going to find that is with a venous plethysmographic studies, and those are hard to come by. For instance, we don't do that at Ohio State, for instance. I know Cleveland Clinic has it, but that's a hard one to get. But if you really wanted to answer that question of venous pooling, you're going to have to find somewhere where you can undergo a venous plethysmographic study, and that's tough. Let's see. Somebody just gave me there was a message up here I was supposed to look at, and it disappeared. You want to shoot that message back up here? We'll see if it shows. I'll wait for that to show. Let me go on to the next one here. How does a doctor diagnose this from just lymphedema? Thank you for the nice comments here. Well, the easy way would be if there's any component of fixed swelling within the dorsum of the feet that never completely abates with elevation overnight, then you've got at least early stage 2 lymphedema. So look for fixed swelling within the feet or toes. That's the easiest. But a lot of these patients that end up having a lot of cutaneous hardness or discoloration consistent with stasis in the distal and mid calves. Those patients clearly have lymphedema at some level. If you were to biopsy their skin, they would have dysfunctional lymphatics. So I would say skin changes, cutaneous fibrosis, and fixed swelling within the feet. And remember those pictures I showed you of the feet, they were moderately swollen. Here's a question asking about liposuction. Does the lipedema recur after liposuction? That's highly variable. I mean, if you look at the studies out there, I think there's probably a publication bias, and they have great long-term outcomes all the way out to 8 to 12 years. But again, I think there's probably some publication bias. But the answer to that is it just depends. I do see sometimes liposuction fail when patients fail to maintain at least somewhat of an ideal body weight. The patients that gain weight, their lipedema tends to get worse again. In an ideal world, you would have, to answer your question, you would have suction lipectomy at an early stage as opposed to a late stage. That's ideal. Again, the biggest issue is trying to get it approved from insurance. So let's see here. I think I know what that question they were asking here. Let's see here. Answer that one. As the research continues, is there a standard of care established? Well, again, I would draw your attention to the just published US standard of care for lipedema, and that's already starting to undergo some modifications. It's a dynamic document. I think we'll modify it in the future. And here's something I'm not sure how to answer. Let's see here. Oh wow, here's a great question. Brilliant. Excuse me. What will it take to get the insurances to recognize the validity of lipedema and cover treatment to manage it? I think it's just more clinical evidence on the impact of lipedema. It exists. It's a real entity. We just need more studies. And I think just like having a U.S. standard of care guideline, I think that helps getting insurance to recognize the morbidity of lipedema. It's a bad disease. Just time, but it's getting better. It's slowly, I will say, I'm seeing more and more cases of lipedema suction-associated protein lipectomy approved these days. Here's a question. Is this now being taught in medical school? I'm a physician, had never heard of it until my mother was diagnosed. Boy, that's it's just like lymphedema. I just hardly ever and to answer your question, I don't really know. At least when I was lecturing to the fourth year medical students here at Ohio State, I definitely referenced it, and I had about 5 minutes to do so. But as a whole, no. The answer is no. It's something you learn when you're out in practice, unfortunately. Let's see here. Here's another question. One of the differential diagnostic criteria we often hear is lipedema is symmetrical and lymphedema is usually not. And that's there's a lot of truth to that. There's always exceptions to every rule. Do you typically see bilateral symmetrical lymphedema in patients with lipo-lymphedema? I would just say relatively symmetric. Yes, it is. If I'm going to, like most edema, if it's going to be worse, it's going to be worse on the left side, probably from chronic compression of the left common iliac vein by the overlying right common iliac artery, but it's relatively symmetric. And if you go back, you can go back and review the images I showed you, you could see that even in those lipolymphedema patients, the swelling was relatively symmetric. So good question. Do you still recommend BioFlect leggings for lipedema? That's the question. BioFlect, Cisalis is another brand. These are leggings that have a micro massaging weave to them, and very good. I think these are helpful, and yet the answer is yes, I do recommend them for lipedema in the sense that I don't know they're doing much they'll help with any orthostatic edema. They're not going to be great for severe secondary lymphedema, but they're definitely helpful with lipedema and orthostatic edema. And they also help, I think, obviate subsequent cutaneous fibrosis as well. So a good trick is to have a patient wear BioFlect or Cisalis leggings or capri pants, and then you just overlap that over a knee-high 2030 stocking, for instance. Let's see here. Somebody wants to discuss. Okay, if he wants to contact me, my email is Stephen, that's with a V. It's not a PH, it's a V, Stephen.Dean@OSUMC, that's osumedicalcenter.edu. So just contact me about your question. How much time is covered in a GP's education on the lymphatic disorders? Gosh, I knew Stan Roxon just addressed this question in general, in an article he wrote not too long ago, and it was minimal. I think it was 5 to 10 minutes. I mean, there's hardly anything on there. It's quite unfortunate. Any role of ketogenic diet on lipedema? Absolutely. Low carbohydrate diets. It doesn't just have to be a exclusive ketogenic diet, but any low carbohydrate diet is extremely important for lipedema. To a T, your lipedema patient will tell you that their leg pain and swelling is so much better when they follow a low carbohydrate diet. The minute they relapse, their leg pain and swelling worsens. Here's a interesting question. A patient that has spinal stenosis, obesity, urinary incontinence, and proximal bilateral extreme lymphedema, could this be lipedema? Absolutely, it could be, because again, I'd suspect that patient you're describing right there has a hypermobility spectrum disorder, and those patients have chronic low back pain. You don't necessarily have spinal stenosis, but actually they can with time because of the loose ligaments. It leads to premature arthritis in their spine and then spinal stenosis, and the urinary incontinence would go right along with the laxity, the pelvic laxity that I referenced. And then it could be a type 2 or upper leg type proximal lipedema. And it's a clinical diagnosis. When I would see them, I would do a Baton score on them and see if they're hypermobile. When you mention spinal stenosis, sometimes you're aware this is an elderly population. You have to keep in mind that when you have your patients with hypermobility spectrum disorders, they're predisposed to premature osteoarthritis. So their once hypermobile joints can actually rapidly become somewhat fixed because of the hypermobility. And that's why, so you miss it in that scenario. Let's see here. Here's a great question. I'm going to end here because I'm going to have to get back to clinic. This last question, I love the question. The Europeans, which by the way, that's referencing the international consensus document that I talked about. The Europeans say there is no edema and lipedema. How do you understand that, considering the bioimpedance work of Brzezinski? What about their ultrasound imaging showed no fluid? Also MRIs with fat reduction imaging showing no fluid. Great question. Those are the two references they give in that article. And by the way, I thought it was interesting that they're looking for edema in the thighs with the ultrasound cases they show. I mean, if I'm going to look for edema in the leg, it's not going to be in the thighs. I'm going to be looking down in the mid and distal calves if I were going to prove my point that there was no edema and lymphedema. So that's number one. Number two, they do quote one MRI scan, or they reference one MRI scan that showed no fluid in the setting of lipedema. I would simply say that based on these bioimpedance and perimetry studies that I've showed you, and there's more to come from their institution on where some of their additional work is going to support this, I'd say the MRI is just not an overly sensitive study for early fluid detection. That's how I would say. I would say that your bioimpedance and perimetry are much more sensitive methods of detection of early edema. I think as time went on, of course, you're going to see lymphedema even with an MRI, but I think you're just looking at early ones. So yeah, I just, I like that article. There's a lot of good information in it, but to say there's no edema and lipedema, I think I've shown you that's not the case, whether you want to consider it orthostatic. Then of interest, they even state that patients with lipedema can have orthostatic edema. So there is edema. They've even said it in their own article. So again, I don't want to bash that article because it's very good, but I don't agree with that point. So I appreciate all the people that have tuned in and your interest. These are some really, really good questions. So have a great afternoon, everybody, and thanks again for tuning in. Bye-bye.